shot in my clutch and I told you there's something inside the program, nothing to do with the first one. I'm getting tired.
Welcome, welcome, welcome. For those of you that don't know, I'm David Elwood. I'm Malcolm Weiner Professor of Public Policy and co-director of the Malcolm Weiner Center for Social Policy. And Malcolm Weiner is here in the audience, and so I'm very grateful for at least extending my name, but also for all he's done for us. The Malcolm Weiner Center for Social Policy, as most of you know, is a vehicle here within the Kennedy School where we do a great deal of work surrounding poverty, welfare, and those kinds of issues. Tonight we're extraordinarily fortunate to have three remarkable individuals here to talk about an action agenda for children. And in particular, David Hamburg is going to share with us a variety of thoughts that are really a summary of things that are in his new book, Today's Children, Creating a Future for a Generation of Children in Crisis, from Random House. And I really strongly urge it to all of you. There are certain people for whom it is very difficult to come up with an introduction. There's an easy introduction for someone like David Hamburg, which is to read the 7-page short version of the biography. You don't usually get the CV fax because you may not have enough paper in the fax machine. But there are things like David Hamburg is the president of the Carnegie Corporation. He's been president of the Institute of Medicine and the National Academy of Sciences. He's been president and chairman of the board of the American Association for the Advancement of Science. He has been professors at lots of different places, most notably Stanford University, where he is on he's a trustee and vice chairman of their board. And most importantly, David Hamburg, and I'm sure he regards his most important contribution, was he was head of the Division of Health Policy here at Harvard University for a while, and actually was a founding member of the founding father of the organization, which is now the Weiner Center. So I'm sure that's very impressive. But it is not those kinds of achievements which come to mind for me as someone who's dealt with David over the years in a variety of different contexts. It's a different set of words that I think of. Words like, and this is very impressive since my introductions up in my office, that I'll remember these words. Words like wisdom, for this is a man that has spent a great deal of time learning. But there are also words like future. Few people that I know are more focused on the future. The focus is not just on children, for he is someone who's spent a lot of time in psychiatry and focuses a lot on children and children in distress. But he's also a man that spends a lot of time worrying about our future in the form of arms control, international relations. He was just saying on the way over here, by the way, he just came in from Switzerland the night before last. He's very interested in ethnic issues. It's very close to being a kind of Renaissance man in that respect. This is a man that's interested in comprehensive kinds of things, interdisciplinary work. David seems to look at an individual and not see something that only an economist could understand, or something that only a social psychologist could understand, but seems to think that all of those parties need to come to the table to think about how to best serve and how to best deal with these kinds of issues. And there are two other words that come to mind very, very strongly. The first is education, and the second is change. David, throughout his career, has invested a very major part of his time educating people at all levels. He's been a professor. He's certainly been involved with students. Many people in this room may well have studied with him. But in addition to that, he thinks it's critical to educate leaders, people that actually make the decisions. So he's invested much of his own time and the resources now of the Carnegie Corporation and other institutions to training leaders in the House and the Congress and the governorships and all over the country, as well as small groups of local providers to think about ways to provide help and support. And of course, Carnegie Corporation itself is heavily focused on issues of education. And finally, change. for someone who's been in so many trenches and so many places and seen so much of the way the world is, it is remarkable that he can still believe as deeply as he does in the goodness of people and our capacity for change. The optimism that he's always got a new idea and always got a new plan, always explains why this next administration is going to get it right this time. And maybe this time he's right. I hope he's right. In any case, would you please give a warm welcome for Dr. David Cameron.
Thank you so much. In the fraternity of Davids, that's a very generous introduction, which I appreciate deeply. I do have to sort of correct or augment one thing, that is this business of my educating leaders. What I do is connect leaders with people like David Ellwood. I'm in the business of linkage, that is connecting experts in specialized subjects with policymakers and policy advisors. I feel that foundations have a very rare and special opportunity to make such connections, but it's bringing others as being a broker for ideas and analysis. It's a great turnout on Friday the 13th, my God. I'm not superstitious or anything, but I do really appreciate this. I guess it reflects the concerns that are rising in the society about the fate of our children. I'm awfully glad to be here. For me, the Kennedy School is unique in the world. I wish it were otherwise. I mean, I wish we had a lot more Kennedy schools in this country and other countries. But nevertheless, it is a great tribute to the leadership of this school and the faculty and students here. Very special. And I recall the years I spent here with great pleasure. As a matter of fact, I came here with the notion, my task was to build a university-wide health policy program, and I thought I would spend most of my time in the vast medical public health orbit of Harvard, and I ended up spending, I guess, about half my time here because I found it just so fascinating or seductive. And it's been a privilege since I left a decade ago to just switch hats slightly and see to it that Carnegie would provide plenty of support. I guess we are kind of a major stakeholder in this. Another line of support from Carnegie in the past decade, very happily, has been Tour de Avance. And I must say it's a privilege for me to be on this program with Dory Rodriguez, who in my mind is one of the most brilliant innovators we have in the field, as you'll hear in a moment. From, I guess one other thing I ought to say, I won't tell the joke because it would take too much time, but it's just a punchline. Most of you will know it anyway. With Malcolm Weiner in the audience, and Lee Shore in the audience, and David Ellwood in the audience, and Joe Newhouse in the audience, you know, the joke is Noah is in the audience. If you don't know that joke, I'll tell you later. But that's the punchline. Governor Richards from your state, Gloria, who is, I think, probably the funniest person in American public life, but also a very serious, thoughtful person, made a remark right after the Los Angeles riots, something to this effect, that she said, those hoodlums who burned much of the city were, not so long ago, our children. It's a very profound remark, because the path we're on now, in my judgment, will generate a larger and larger proportion of what she called hoodlums. And we have a decision to make pretty soon as a nation. Do we want to stay on that kind of a path, or do we want to seek a better path? Other paths will not be easy. What I'm going to sketch out very briefly is not a simple or assured better path, but it certainly has opportunities that do not exist in the path we're on now. And we have to decide as a nation what we want to do about that. Fundamentally, I want to sketch very briefly the search for ways to meet the essential requirements for healthy child development, healthy adolescent development, healthy in a very broad sense, decent, vigorous, constructive problem solving, all of that. Thereby to reduce the casualties that we're now taking. Some of them appear in the educational sphere, some in the health sphere, but there are very serious problems throughout the society. The book that David kindly referred to does try to deal with the problems in the whole society. For example, in the affluent sectors, there's a very serious problem of parental disengagement. On the average, parents are spending about half the time with their children that they spent 30 years ago. There is a problem with parental disengagement, and there's been a tremendous amount of family disintegration, and it's very hard to meet the essential requirements for healthy child development with revolving door family situations, even with lots of money. Money will only go so far in substituting for for meaningful parental contact and responsible caring adults. But I'm going to focus tonight on the toughest problems, which is the problems of persistent poverty in the inner city. And all the problems that exist throughout the society are carried to the nth power under the conditions like South Central Los Angeles. There is a developmental sequence of experiences and opportunities and interventions that tend to promote healthy child and adolescent development. But they do require not only the action of individual families, which they centrally do require, but also the action of larger social units and indeed the entire society. And I personally think that in some way or other in this vast heterogeneous society, difficult as it is, we will have to come to think of ourselves as something like an enormous extended family. I think that's a metaphor of great utility for this problem. And we are all tied together by history and in some kind of shared destiny, and it requires a strong ethic of mutual aid. We heard today from Dr. Hyman about the tuberculosis problem in society, and that is maybe a good indicator of this concept, because if you think you can wall off the inner city and the problems there are limited to the inhabitants of the inner city, you cannot. Tuberculosis will come out and spread, and lots of other, quote, diseases in a broad sense will spread, not least crime and violence. So that even quite apart from any humane compassion we might feel, there are very practical necessity for the society at large to address this problem. And I think the right question to ask is something like, can we do better than we're doing now? Because no use talking about some hypothetical ideal of perfection or eliminating all the casualties, but rather in making a substantial reduction in the casualties, finding ways in which a much larger proportion of the young people could grow up in such ways that they could, for instance, enter the mainstream economy. There are costs, of course, substantial costs, or rather investments, but we're paying very heavily now. We're paying in disease and disability, and ignorance and incompetence, and crime and violence, and alienation and hatred. And we would certainly be much better off if we can find ways that a larger proportion of our kids would grow up healthy and vigorous, decently constructed, inquiring, and problem solving. To do that, we have to get the facts straight to the extent that we can from biomedical and behavioral sciences. There is a remarkable consensus that emerging in recent years in the relevant parts of the scientific and professional community about the factors that influence child and adolescent development and about ways to provide conditions that will tend to promote healthy child development, prevent a lot of the damage going on. Moreover, all over the country there are innovative programs, brilliant ones, like Gloria's in San Antonio, that show what can be done, but typically you find only model programs, 6 or 8 or 10, where you need 500 or 1,000 across the nation. Carnegie had the privilege of supporting many of these programs, as well as much of the underlying research, and so we have some sense of what might be possible if the nation can find ways to scale up these opportunities and have a sort of developmental sequence of experiences and interventions that would provide encouragement, stimulation, guidance to children in ways that they're likely to pursue education and protect health. It makes sense to start intervention early with family equivalent functions. That is, to the extent it's possible to strengthen families in an era of great family damage, there are ways to strengthen families. And beyond that, to supplement or augment families so that the pivotal institutions that impinge on child development can actually perform, to some extent, family equivalent functions. In some ways, it's akin to what happened early in the Industrial Revolution, when the economic functions of the family largely moved out of the home. And now, to some extent, partly by choice, partly by necessity, the child care functions, the growth-promoting functions, are partially moving outside the home as well. And we don't yet have the institutional arrangements to cope with that very, very effectively. But it is possible to sketch out a developmental sequence of interventions, which I'll state just very briefly, starting with prenatal care, going on to preventive pediatric care, parent education, social supports for young families, high-quality child care and preschool education of the Head Start variety, and then on to a major upgrading of the elementary and middle grade schools in partnership with strong sectors of American society. And I have tried to develop in some moderate detail and with some considerable documentation in Today's Children that kind of developmental sequence. It would take hours to do it here. I'm quite prepared to do a Catholic-style 3-hour harangue, but I guess it would not be appropriate. Let's take an example. Now, I'll take a couple of examples of this sequence I've just sketched. The enlarged vision of prenatal care is a very good one, I think. There is very considerable evidence of serious and indeed lifelong damage that can be prevented by adequate early prenatal care, particularly first trimester, that requires active, systematic outreach to connect with young women in poor communities, typically adolescent, socially isolated, very scared, poorly educated, but nevertheless well-motivated young women, and to the extent possible, young men. So the outreach for early medical care is important, but the enlarged vision has to go beyond medical care. There's a very strong educational component to prenatal care if it's done right. Education of the young parents about how they can take better care of themselves and care of the baby. But also, in poor communities, it's a tremendous opportunity to see, in effect, what are you going to do with the rest of your life? Further education, job training, to connect with whatever services may be appropriate to enlarge vistas about future living. It's a great opportunity for a two-generation intervention, helping the baby and helping the mother and, to the extent possible, the father, an opportunity to change course for the remainder of their lives, as well as to take better care of the child. A very helpful element in poor communities is to construct systematically social supports for the young mothers particularly. There's a program called Resource Mothers. It was pioneered by Governor Richard Riley in South Carolina and his colleagues some years ago. Riley, for some time, was a fellow in the Kennedy School. And that program has spread to a number of other states. It's poorly funded typically, always, like most of these good programs, kind of hanging by the thumbs. But what it does is to find very capable women in the communities who have some knowledge of the communities, some credibility in the communities, who relate to much younger women and help them in a variety of ways. For example, to determine the community resources, almost always more community resources than they're aware of. You almost have to be kind of Einstein or Sakharov to figure out how to use community resources, and these resource mothers make it much simpler than that. So that there's the prenatal care, in my view, the enlarged vision, has an early medical component, a major, big league educational component, and a social support component in poor communities, so that you really have the opportunity to change the course of the lives of the people involved on a two-generation basis. Now, obviously, you're not asking the obstetrician to do all of that, and how you put the pieces together is a complicated but doable proposition. There are good models in the country, but we need many more. So you can then say, well, all right, supposing you did all that and you would greatly reduce these dreadful infant mortality figures that we have, among other things. You greatly reduce the low birth rate babies that have such terrible long-term consequences. But for what? For what? To accelerate them into a brick wall later? You've got to think of, none of this is like, say, the polio vaccine, where one shot will do it. It can be a very important formative experience with long-term, changing the probabilities for the longer term. But it has to be connected with a series of other experiences that come along. Well, baby care after the baby's born with emphasis on disease prevention, health promotion, parent education to strengthen the competence of the parents and build close parent-child relationships. Later social support networks among young parents who can give mutual aid, self-help, with some professional linkage as they may need it. Then child care of high quality, especially in daycare centers that kind of pool resources that show strikingly beneficial results in poor communities. Preschool education in the Head Start mode. and then on to better school experiences. The Lee Shore and Julius Richmond have recently published a piece that suggests taking the Head Start concept and pulling it back as far as prenatal care. I think that's a very good idea. Take the essential elements of Head Start and make fundamentally a 0 to 4 integrated program that could offer the kind of developmental sequence of growth-promoting experiences. I won't say anything about the early pediatric intervention except to give you one fact that is almost too awful to believe. And if you ask yourself, where do you suppose we are in infancy immunization in this country? Infancy immunization is extremely important, beneficial, the most cost-beneficial intervention that we have in medicine and public health. If you take non-white infancy immunization and stack it up as if it were a nation, that part of our nation that is non-white infants, we are 70th in the world, 7-0. So lots of developing countries, thanks to UNICEF campaigns, do a lot better than we do in that regard. Even if you put it all together as a nation, we're somewhere in the 20s. It's not a big deal. It's not a terrific accomplishment. That's where we tend to run in lots of children and youth measures in education and health, 15, 20, 25 as a nation. If you separate out the inner city, then we're always way up there. So that doesn't make an awful lot of sense. It really doesn't. And it might make some sense if we had no notion of what to do, but all we have to do is look at Western Europe and Japan, and for that matter, the developing countries, and see it is possible to do quite a lot better. I want to jump ahead for just a moment and say a word about this issue of building parental competence, because to the extent possible we want to do that. Although you can make alternate arrangements or supplementary arrangements, as I've been sketching, that are actually essential, nevertheless, to the extent that you can strengthen the families, it's a tremendous advantage in terms of the conditions necessary to meet the essential requirements for healthy child and adolescent development. And I think that it is possible. We have models that show you can build in very meaningful parent education or parenting skills experiences at different levels of opportunity. In prenatal care, I've mentioned it. In early preventive primary health care, well, baby care, you can do it there. In the child care, daycare arrangements, you can do it there. In the Head Start, you do it there. So that in the early years, there are a number of opportunities to come back and to reinforce. And if you miss the opportunity in one place to catch it another place, and what do I mean by parent education? I mean information about child development and child health, but I mean more than information. I mean shaping attitudes that are constructive and hopeful. I mean fostering close relationships between parents and children, promoting the conditions that people can get real joy in seeing the children development, that children develop, the wonderful discovery of the different phases of child development. How people can learn to take pride in the sheer stamina of being an effective parent, resilience of coming back, a political campaign. Coping with the predictable, learning to cope with the predictable transitions. There are never predictable transitions. Learning how to use community resources, learning how to seek and accept and give help as it may be necessary in and around the family. Those are the key elements in really substantial parent education. On the upgrading of elementary education, I'll just mention some names like the NOAA joke. Jim Comer's pioneering work in New Haven, now spreading in a number of states throughout the country. Bob Slavin's pioneering work, building to some extent on Comer's, out of Johns Hopkins, the Success for All program in the Baltimore metropolitan area, shows that you can go into the most god-awful neighborhoods and turn schools around and get good results over an extended period of time. It is possible to do that. It isn't even all that arcane anymore. It's not easy, but we know enough about it now. Just take one thing from Slavin's program, just one element. He says, I think correctly, that there is a crucial thing about early elementary school, and that is learning to read. Whatever else is important, learning to read is crucial. I would add to that one other thing, I'm sure you wouldn't disagree, and that is some kind of positive attitude towards school. If you get those two things in the first few years of elementary, the chances of doing well thereafter are greatly enhanced. And so he's got a big league program of individualized reading instruction, reading tutors in the first few years of elementary school, which is not the only thing by any means, but is a very important component. It's quite simple in a way, but very important. What the Comer-Slavin thing, what they do is in a way like Head Start upgraded. That is, they don't just look at cognitive stimulation, they look at social learning as well. It's the human experience as well as the cognitive stimulation that is so important. Like a significant addition to Comer's program after the very beginning was adding mainstream social skills. However, when they feel about preserving cultural diversity, it is important to have certain mainstream social skills if you're going to get into the mainstream economy. And that component is another important component of what goes on in these Comer schools and Success for All schools. So, now, middle grade schools. We put out a report in 1989 called Turning Points, which I summarize in Today's Children, which I have unabashedly recommend Turning Points to you. Not only because it would make a revolutionary transformation, it has begun to do so in schools throughout middle grade schools, junior high, middle schools, but also because many of its principles are really quite applicable to elementary school and to high school. At the moment, there's a special interest because one of the authors of that report, the task force that I appointed for that, included the then governor of Arkansas. And he made a substantial contribution to it, so much so that I asked him to represent the report on national television, and some of you may recall seeing Governor Clinton making a brilliant exposition of that report on several major national television programs. I hope that he remembers that, and we may see some kind of adolescent development initiative. One of the peculiarities of the report is that it breaks down bureaucratic walls. It strongly links education and health, as I think you must. I think any concept of education without health or any concept of health without education is certainly foolish with respect to children and youth. I personally think it's foolish throughout the lifespan. But anyway, let me just read you, to be brief, 5 or 6 key concepts, shorthand, of that report, which in fact, as I say, have wider applicability in elementary and secondary education. 1, developmentally appropriate education, that is, the content and process of learning should mesh with the interests and capacities of the child in each phase of development. 2, schools of small units created on a human scale, very important and very inexpensive. Just break up the warehouse schools. Make schools within a school or houses or whatever you want to call them. 3rd, sustained individual attention in the context of a supportive group, which is a pervasive theme, and the report has a lot of ways in which that can be done. Next, students learning to cooperate in class with an eye on future work and decent human relations, that is, through the techniques of cooperative learning and through supervised community service. We actually recommend, at the junior high level, required community service as an academic experience. 2 more points. Stimulation of curiosity and thinking skills, especially at this level, through the life sciences, which include high-risk behaviors, so that every component of the life sciences curriculum, students learn about the high-risk behaviors, which are so crucial in that time of life when they're exploring new behaviors, age 10, 11, 12, 13, trying out new behaviors, many of which are risky, and the consequences of which need to be deeply appreciated by them before it's too late. And that leads me to the final point, the linkage of education and health, for example, in school-related health facilities. I've got to close in just a minute. I know I'm too much immersed in this stuff and could go on too long. I am told a student said, was asked, who was Socrates? And the student, I think it was an elementary school student, said, well, Socrates was a philosopher, and he talked a lot, and they poisoned him. So I'm mindful of that Socrates problem, but I want to, before I leave this podium, I want to underscore something that I dare say Gloria would be prepared to reinforce, and that is the general importance of social supports in overcoming disadvantage. to the extent that we are dealing with a lot of smashed families in these communities that are not only very poor, but very depreciated for a long time, it is very important to find ways to construct social supports, as I was saying, like the resource mothers, various small groups, one-on-one, mentoring, some way to connect responsible caring adults beyond the family with individual, say in early adolescence, to construct small groups of peers that have enough responsible supervision and guidance that they can be a constructive influence rather than an undermining influence. Again, some notion of a kind of extended family. We're bringing out a report. This is my final advertisement of the night. We're bringing out a report in the middle of December. A group co-chaired by Jim Comer of Yale, Wilma Tisch of New York, and Jane Quinn, who's a leader in the field of community organizations for youth. It's called A Matter of Time, Risk and Opportunity in the Non-School Hours. What it does is to take the non-school hours and put them beside the school hours and say it is possible to construct an array of useful opportunities, growth-promoting opportunities, over the whole waking time. It doesn't deal with the sleeping time, but the waking time of young people. And it again follows the model we have used elsewhere of looking around the country, not only through research, but at interesting innovations, some of which have been evaluated systematically, most have not, but carefully observed innovations around the country. There are a number of organizations that are doing terrific things. I'm proud to say we support some fraction of them, not nearly as many as I would wish. Youth-serving organizations, scouts, clubs, etc. Adult service organizations, Rotary, Kiwanis, what have you. Churches, the National Congress of Black Churches, for example. Minority organizations, professional organizations. There are a lot of organizations out there in the communities that are getting more and more interested in young people. They typically have a precipitous fall off in their engagement in early adolescence, which is terrible. One of the things the report deals with is how they might engage young adolescents in their programs. They typically do much better in middle class than in poor communities, which is terrible, and the report contains a number of suggestions about how they can do better in poor communities. But it begins to add some reality to this metaphor of extended family. If you had enough organization and support so that these outfits in the community could connect with the schools and could cover the time with a constructive array of opportunities, especially in these crucially formative early adolescent years. Now, I want to close where I began with just saying a quick word about the cost issue. It comes up over and over again. It's a mixture of interventions which cost a lot of money with opportunities and experiences that cost less money. But basically, this growth promoting sequence, or the prevention of damage to children, involves really very modest expenditures in comparison with almost any of the other major concerns in society. Modest expenditures now for large savings and large benefits later. The problem is not so much what needs to be done and how to do it, but rather the time span. Can we look ahead far enough? Can we see beyond tomorrow? And do we care enough to make the investment for what is in fact the future of our society? Thank you very much.
Thank you very much, David. And I would again encourage you to pick up the book. Today's Children, Creating a Future for a Generation of Children in Crisis, and also the Turning Points. I agree with you. I think it's a really extraordinary document. All right, our next speaker is Gloria Rodriguez, and she's the answer to the question, what kind of person could start out as a school teacher, a somewhat frustrated school teacher, take on a program that hardly existed anywhere, create a new program, and within 15 years have Prince Charles come visit the program. Not only Prince Charles, the First Lady of Mexico, 2 visits by the First Lady, the current First Lady of the United States, Indeed was listed as one of the 10 outstanding and pioneering programs in family literacy by Barbara Bush Foundation on Family Literacy. Who could start a program for parenting education that would also be described as, quote, not only for parent education, family support, but also for programs in the promotion of mental health and prevention of socioeconomic problems such as poverty, child abuse, neglect and delinquency, and school dropout. She's gotten this program, and Gloria have gotten awards from a remarkable array of different kinds of organizations, ranging from a national award for prevention of child abuse, to Inspector General's report on services integration for families and children in crisis, to being featured all over ABC News, Good Morning America, New York Times, and the like. She's also gotten some unusual awards. For example, she received the first Attitude Award, something my daughter she's 15. Attitudinally, presented by Lifetime's nationally syndicated program called Attitudes for changing attitudes towards family service. Another award is the Temple Award for Creative Altruism from the Institute of Nomadic Services. She's been on a remarkable array of boards, ranging from Governor Ann Richards' transition team in early childhood education. She's currently on the Governor's Head Start State Collaboration Task Force. She even, and this is truly extraordinary, and this is the sort of thing academics are really quite taken with. In 1990, the University of Texas Barker Center of Texas History established the collection of Gloria G. Rodriguez. And I have no idea what that's all about, but it's a remarkable collection in the history department. I mean, that's really. Speaking of turning points, I did ask her sort of what happened. How did this all happen? And she did describe a graph that she has of showing the growth of Avanci sort of going up like this and so forth. And then there's a turning point, and the graph goes up like that. That turning point was when David Hamburg visited her. And came back and started every place he went saying, I just had a religious experience. And all of a sudden, the New York Times and everybody else and so forth came. So with that, let me ask you to give a very warm welcome to Gloria Rodriguez.
Thank you so very much. It's indeed a great pleasure to be here. And it is true, I do have that chart. I call it BC, before Carnegie, and after Carnegie. So it really goes this way. The Avanza program, which is cited in Dr. Hamburg's book, has as its mission to strengthen low-income families through support and education. It has many of the important elements that Dr. Hamburg alluded to, and I will mention some. I did pass out a few models of our program, but the very important component of our program is that core, that center circle, which is the parenting program, where parents come to classes once a week for 3 hours for 9 months to learn how to be better parents. They take classes in child growth and development, make educational toys that will prepare them to become teachers of their children, and we link them to the different agencies in the community that can alleviate the stress that impedes effective parenting. So we begin with that very important part of development, which is the development of a child, whether it's in the womb or to the age of 2. So we believe the earlier, the better, and most important. The child is the entry point to the entire family. We believe that we will start with the strengths that the parent comes to our program with, and that is the love that that parent has for that child. And especially when a child is so young. So they might not be in a program to help themselves or to feel that there's hope for themselves and a better future for themselves, but they do hope that things can be different for that child. So that is our hook, and as soon as we grab her and provide the best types of services possible, then we try to get every member of the family as well, including the father, which has basically been left out of a lot of the social delivery services. Our program is preventive, it's community-based. We go to the people in one neighborhood, in one geographic area. For example, in a housing project, we start there and say we are going to take a certain census tracts and will be the family center, supporting and advocating for those families in that geographic area. We're comprehensive, as Dr. Hamburg said. We integrate numerous interdisciplines together, such as parent education, with health, with mental health, with nutrition, with quality daycare, family planning. We provide field trips and fun, stimulating, memorable experiences as well. What in essence we are trying to do is strengthen that family unit, bring about positive experiences and traditions that can continue after the program ends. Our program is also sequential. From parenting, we go to literacy, as the model shows. The bottom part of the circle is the intervention for the parents. So they go from the 9-month program in parenting to literacy, offering classes in English, their GED classes to get their high school degree, and college courses. From English, we try to hook them into the job market, and lastly, housing and community development. The upper part of the circle is the track, the path that the children follow. From parent education, we hook them to the existing Head Start program in the community, where we have formal agreements with Head Start that the Avance babies will have first choice in the Head Start program, so that there can be that continuity of learning. So the children go from parenting to Head Start, our early childhood program, and then we try to have parenting classes in numerous schools so that we can offer tutoring, mentoring, scouting, and different types of experiences that can enrich the life of the person. And lastly, all Avance mothers and children know from the very beginning of that program that if they want to go to college, Avance will provide a scholarship. So they start setting goals and paths for themselves. Of course, many of them qualify for assistance, but they have never known how to access the systems. And so Avance then becomes their advocate in assisting them in that way. We have a philosophy in our program that we treat the parents and the children with dignity and respect. As CEO and president, if anyone is not treated as such, they will be immediately fired. But I have no problem with that because the majority of our employees are graduates of Avance. From 60 to 80% of the employees have gone through our program, know what it means to be treated with dignity and respect, and do the same thing to the other participating mothers. To me, if you ask me what makes the difference in Avance, I have to say this is the most important element. In order to, the parents don't only need knowledge from a curriculum. There's all kinds of dynamics that go about, that Dr. Hamburg alluded to, that make the difference. They also need to see role models, people that can be the examples of good parents, people that have continued their education. 95% of the mothers that we first worked with at Avance had dropped out of school. If they come to Avance to work, they must get their GED, and Avance will provide the hours to, and facilitate them obtaining their GED. They will also pay for their college education. So they become the role models of people that are good parents, that are getting their education, and that are working, and that have succeeded. And this is what individuals need. We also have a culturally sensitive curriculum that's both provided in English and Spanish. We offer transportation and childcare that is essential so that the parents can be enabled to learn the different parenting, education, and job skills. And another important component that Dr. Hamburg mentioned was the social support network. I call it building that network of neighbor helping neighbor, or having the extended family that I felt when I was very frustrated as a school teacher, and I had all these children from 4 classrooms that were supposed to fail, put all under one class and said, in December, age 6, it's too late for these children, try to do something with them. I had to really go back to my own background and say, what made the difference in my family, where I came from a very similar community. My father died when I was 2. I leaving my mother a widow with 5 girls. I lived right next to the housing project where I started the first Avanza program. But one important element in my own personal growth and development was a strong family unit. Even if I didn't have a father, I had a grandfather that moved in. I had an uncle that lived next door. I remember the concept of neighbor helping neighbor. And I wanted to make sure that if it helped me, then it would help other low-income individuals. And that's what we're recreating in very high-risk communities. Another concept of our program is that we do not have the philosophy of come and get it. Here I am behind the desk, come and get it. We go out and extensively outreach the families by knocking on their doors and saying, do you love your child? Do you want the best for your child? Do you believe in education? And if the answer is always yes, and we say, we are here to help you help your own children. I implemented, as I said, the program 20 years ago out of frustration as a school teacher. The school system, as it was structured then and now to a large extent, is not designed to work with children who have limited experiences and who have parents who are poor, from a different culture, and who are depressed and under stress due to numerous multifaceted social, health, and economic conditions. I recall those children that I worked with. They would hold a pencil like a dagger. They could not even make a circle. They came to school with lice, and the parents were supposed to take them home because they had a policy that children with lice could not come to school. There were many things that really frustrated me, but the most frustrating thing was when I went to these parents of these children and administered an informal attitudinal survey. I wanted to know, what is it that they believe, what are their attitudes as a parent? I asked them, when does education start? When do you believe education started? And the parents said, in the schools. Who are their first teachers? Those teachers. What do you see your role to be? My role is to take care of the child's physical needs. How far do you think your children will go to school? Around the 7th or 8th grade. How far did you go? Around the 7th or 8th grade. That is when I decided to leave the school system. At first I thought I was going to get my principal certificate and change it. But then I decided, no, we have to help the parents, help their children, and get them ready for school. And we have to do what many of what the settlement homes did to the people that came to Ellis Island. Help them learn how the systems work. Help them understand what is expected of them in the school system. Support them with their language and jobs and housing. And that's what I thought, where I thought I would make a greater impact. Many poor and minority children for many generations have also been ignored, neglected, and discarded like those children that I worked with when they were set aside. They never had an opportunity to develop their potential and to partake of the fruits that this great country has to offer. Instead, one finds many of these children today in the streets committing crime and violence and becoming the hoodlums that you refer to. For too long, well-intended but inefficient systems and ineffective policies have kept people in poverty. As I was attempting to design a program that responded to the needs of the people, I again was very frustrated with the social service delivery system. I found the services to be fragmented, bureaucratic, providing too little, too late. I found the policymakers and the holders of the purse strings too concerned with numbers, with a cost per unit, and whether they would be able to look good if they worked with people that didn't need as much help. I was also very concerned about how children were put at the very bottom of the priority list. In fact, they wanted to eliminate Avance one time because they said, all right, we'll consider supporting children, but you do not fit in that category because you help parents. You do not help children. Of course, we had that changed right away. The services were inaccessible to the people due to the lack of childcare, transportation, language, and cultural differences. The attitude was that the people should go to them behind a desk, and that if they were able to navigate through the bureaucratic maze, they were treated in a disrespectful manner by employees that were understaffed, undertrained, overworked, and underpaid. Avance is a Spanish word meaning to advance and to progress. It is a non-profit organization that was built on the existing knowledge base and from the creative and dedicated spirit of a team of professionals who were from the same low-income community and who were determined to have their people progress and advance and be productive and contributing members of society. We knew that education was the key to get children out of poverty. In order to improve the education outcomes for children in poverty, we knew that we had to begin the intervention early and to start with the parents, who are the children's first and most important teachers. We had to give the parents the tools to help them help their own children succeed in school and in life. However, we first had to empower the parents with information and support. They had to develop a sense of confidence, hope, and a perception that things could be different and that they could have the ability to create the needed changes in the child's environment. In San Antonio, we have 7 centers, like the one I mentioned, and we are in 8 schools. We're also in Houston, and we're starting in the border cities of Texas, and we're also going to be in 2 cities in Puerto Rico. We need to expand our services to serve more people because our program has been proven to work empirically with a very high-risk population of parents who have dropped out, single parents, parents on welfare. 60% of our parents were found to be experiencing depressive symptoms. We wonder if these parents live in these conditions, how they can have the energy to guide and nurture and supervise their children. What we see in the formation of hoodlums or gangs are children that did not get the nurturance and the support. They had a need to feel wanted and protected and with a purpose, and they just happened to form their own family with their own set of values that are contrary to society's. What we need to do is to have more of these programs to be able to have parents nurture and guide their children. Through our research findings, and we received a tremendous grant from the Carnegie Corporation, we have found that by attending that 9-month program, program mothers tended to be more responsive, more nurturing, to interact more positively with their children, and to perceive themselves as teachers of their children. Parents scored significantly different on standardized instruments, which have been correlated with school success. The program impacted the parents as well as the children. Twice as many of the Avance parents continued their education only 1 year after the 9-month program, which was 60% or so of the parents. We also have conducted a 17-year informal follow-up of the first Avance parents and their babies who are now growing up. In 1973, 95% of the mothers had dropped out of school. In 1991, 94% of the children who attended Avance when they were small had completed high school, received their GED, or were still attending high school and about to graduate. 43% of those children who graduated were attending college. And most importantly, too, we made an impact on those parents. 57% of the mothers who had dropped out went back and got their GED, and 64% of those mothers were attending college. It is very exciting to be here to speak before future leaders or existing government policy makers. We have a great opportunity to stop the suffering, the pain, and the violence that exist in many of our neglected neighborhoods. We have the responsibility to take care of the most vulnerable members of our society, the children and the youth in poor communities. We cannot have leaders in elected or appointed positions of power say what can be done about the terrible, complex problems of our inner cities. Many experts throughout the country who have proven that their programs work, that are cited in Liz Shore's wonderful book, can attest to programs that have made the difference, can tell you exactly what needs to be done. They are not simple solutions. It will take commitment, time, and resources, and the entire community working together to solve the problems. This country needs leaders who value the family and who have strong family values. We need leaders who truly understand what compassion, responsibility, creativity, courage, sacrifice means, and these are values, and who know what these words mean and who will put these words into effective policies and actions. Their records in helping the most vulnerable of our community, the children, the youth, and the poor families, will demonstrate their true family values. Thank you very much.
Thank you very much. And I neglected to mention while she was doing all this, she also got her PhD in child development or something like that. But what to do with your free time. Our third final speaker has gotten her degrees much more directly. She stayed in Cambridge and achieved a really remarkable success. She wrote a thesis, senior thesis, called Knowing No Distinction of Race, Free Black Healthcare in the Antebellum Baltimore 1800 to 1860, which got the Leonard J. Sith Prize for the Best History of Science senior thesis. She went on to, following that period, went to work at the Committee on the Status of Black Americans, where I met her, I'm very pleased to say. She then we went to medical school, and also went to the Kennedy School, where we gave her all kinds of awards. Pretty much all of our awards, I think. The Robert Kennedy Distinguished Public Service Award, the Manuel Carballo Award for Best Paper on Programs for the Poor, and so on. She also worked with a number of the people in this room in an executive session called Making the System Work for Poor Children, and helped us write the reports. I'm hesitant to say she's also been a dean. She was assistant dean of the Harvard University Summer School, and I'm reassured to see there is life after being a dean, because I don't think you're doing that anymore. Good for you. With all this education, you'd think there was no hope. And certainly from this university, but in fact what Cheryl has done instead is work on a remarkable program called the Family Van Program. I'm not going to say too much about it, except that Cheryl is the director of it. And as you look down this table, what you see is three people with very different stages in their professional career, different backgrounds, different directions, but all leading to a direction of really making something work for our kids and our future. And so the last speaker today, one I'm very, very pleased to introduce, is Cheryl Lewis. Thank you.
Thank you very much. This is truly an honor and different perspective. I spent 2 years sitting up there listening to wonderful speakers, so it's interesting to be on this side of the microphone for once. I'll start off by saying that I enjoyed immensely Dr. Hambur's new book, Today's Children, which he devoted to giving all our children a decent start. This lofty goal, in large part, reflects my program's mission. But here in Boston, many of our children aren't even getting to the starting line. And at the end of the week, I'd like to just give you a perspective on what happens every week here in Boston. Every week, 17 babies are born too small to be healthy, 4 of whom weigh less than 3.5 pounds. Every week here in Boston, 22 infants are born to teenage mothers. Every week here in Boston, one baby dies before 1 month of age, and 2 will die before their first birthday. Boston is also home to one of the worst Black infant mortality rates in the United States. Black babies here die at a rate of 2.5 to 3 times that of white babies. To give you some perspective, even babies in Costa Rica have better life chances than our Black babies in Boston. For those of you who may be familiar with Boston's landscape, the problem of infant mortality is most critical in areas like Roxbury, Dorchester, and Mattapan, where 64% of the city's infant deaths occur, and where 60% of all low birth weight babies reside. While these statistics are indeed frustrating and sometimes breed divisiveness, they have also sparked positive action, including programs like the Family Van. Through recognizing the importance of barriers such as inability to pay, transportation difficulties, language and cultural barriers, and daunting institutional practices to prenatal care, which, as Dr. Hamburg mentioned, which has been shown to be very cost-effective and important in improving the chances of a healthy infant, the Family Van involved, and I really did like Dr. Rodriguez's comment that whereas many programs say, come and get our services, we need to start thinking differently, say, we will go and bring these services to you, and I think the Family Van is one example of that. The van itself is a 35-foot long recreational vehicle, seating 9 to 13 people comfortably. Looks very much like a living room, a comfortable living room. It's outfitted with a cellular telephone, an automatic blood pressure machine, health education materials, educational videotapes, and a television and VCR. The van parks at designated sites in Roxbury, Dorchester, and Mattapan, and is manned by nurses, health advocates, nutritionists, and outreach workers from local agencies, including neighborhood health care centers here in the city. To give you a sense of what we do, I can say that our staff really intervene at 3 different levels. First, education and counseling is offered on a variety of issues. Staff on the van share what they know with people who, in many ways, do not trust the system. They attempt to build trust by answering questions on clients' terms. And what I mean by that is all of our services are not only free, but all of our services are completely confidential. We require no information from the patient other than what they're willing to give. Second, referral and advocacy services are an important component of our mission. Our staff act as a proverbial stepping stone for those who do want to take advantage of medical or social services, but who have faced barriers of cost, language, or cultural insensitivity. And I must say, a real paradigm for our program is that there are really good programs operating here in Boston, but for some of the reasons that I cite, people just do not have access to them. Finally, the Family Van offers medical screening for some of the known correlates of infant mortality, like hypertension and diabetes. We also offer pre-pregnancy testing, which allows for the early recognition of a pregnancy, at which point intervention systems can be set in motion. I think it's also important that our staff, many of whom are bilingual, are members of the communities they serve and are able to work in a comfortable setting. The Family Van, in effect, is really a non-threatening and culturally sensitive environment in which to encourage individuals in high-risk environments. Very careful not to say high-risk individuals. I think that is, in a sense, a misnomer. So I say individuals in high-risk environments to seek out ongoing services from those neighborhood health centers and agencies who are poised to help them. Although we are quite young as a program, we only hit the streets last January on Dr. Martin Luther King Jr.'s birthday, we're often asked, how's it going, is the van successful? As a somewhat biased observer, I always answer with confidence, it's going great, it's a tremendous success. But people have not been quite satisfied with mind-blowing reports and really do want numbers. In fact, in our first 4 months of operation, we served 69 clients. We were told that that, in fact, was laudable because programs that work in these communities often take 6 months or so to really build trust and confidence with community residents. Yet in our second 4 months of operation, we served 449 clients. Again, very encouraging. But at least for me, success is not just about the numbers, it's also about the human stories. I recall the story of a known sex industry worker who slowly developed a relationship with a nurse on the van. who also lived in the community. Through encouragement and trust building, staff were able to advocate for and counsel this woman and guide her into a detox program. And there was also the mother of 3 to 4 young children who was desperately concerned about the lead poisoning levels in her home and her community, but unsure of what to do about it. Staff educated her about lead poisoning and scheduled her children for appointments at a local health center's lead screening program. Our program is really just one small program, but I do think that it offers some important lessons for our topic tonight, an action agenda for children and youth in urban poverty, or at least I think it adds to the dialogue. First and foremost, I really do think we need new ways to think about old problems. For example, traditionally maternal and child health experts have defined reproductive health care mainly in terms of health care for women of childbearing age. Optimal maternal and fetal outcomes are the ultimate goals of care under such a system. Also, under the current system, reproductive health is primarily a woman's issue and a medical issue. As a result, most approaches to poor birth outcomes like infant mortality and low birth weight have been directed at women only and provided only in healthcare settings. This strategy is short-sighted. It's terribly short-sighted. We know that infant mortality is a social and economic problem with medical consequences. We know this. It's been shown. Thus, I would challenge all of us to really be open to a more inclusive definition of reproductive health care. As I see it, comprehensive reproductive health care comprises all services that seek to maximize the life chances of the reproductive unit, which I define as a man, a woman, and a child, or variations upon that. It is a vertically designed 3-tiered system that groups services at the community level, at the level of the reproductive unit, and at the level of the individual. For example, key elements at the community level would include basic sanitation services, adequate housing and food, effectual education, satisfactory opportunities for employment and the potential for decent wages, an accessible and competent medical care system, and a system of law enforcement and justice to ensure community safety. At the level of the reproductive unit, appropriate care would entail those services which work to strengthen and maintain it. The survival of the family, both immediate and extended, is crucial to this concept. This often involves family dynamics as it relates to conflict resolution and the intervention of social service agencies in families with unmet needs. It also relates to the importance of religion, culture, and other forms of social support networks that promote social cohesion and create a sense of shared community and common purpose. Finally, all individuals should have the right to services which promote physical and mental health and well-being in an effort to produce useful and functioning members of the society. These services should be personalized and appropriate and should usually be generated at the community level. At this point, I must emphasize the importance of including services for men. I say that my own thinking on the subject has evolved since working with the VAN. 50% of the clients we serve on the VAN are men, 50%. So I've really come to believe that men are a vital part of the family equation, but are really too often neglected. And it makes sense when you think that every woman served by programs such as the Family VAN are really enmeshed in a whole host of relationships, and providers just cannot ever forget this. A program legitimizing the needs of both women and men stands to gain a broader base of support. It's often called buying in the community. If you get men to buy into a program like the Family VAN, you've got a greater chance of success. I know what I've just enumerated is a tall order, but I think it really underscores that there really are no easy solutions for complex problems. Many factors are interrelated, and providers just cannot work in a vacuum. We must not just coexist in our respective agencies, but we must collaborate and coordinate, and I think that is also shown by the Family VAN. We bring all of the resources to bear in the city and help people gain access to that. And this really brings me to my next point. The Family VAN is really an example of entrepreneurship, public service entrepreneurship, that is, meaning taking existing resources and directing them in such a way that new and greater value is created. This program really is a story of collaboration. Many agencies and institutions, all battling against infant mortality, really came together to make this program happen. That meant the support of institutions like the Beth Israel Hospital, the Massachusetts WIC program, the Department of Health and Hospitals Healthy Baby program, 4 local health centers, which I'd like to name: Dimmick Community Health Center, Mattapan Community Health Center, Roxbury Comprehensive Community Center, and Whittier Street Neighborhood Health Center, the Judge Baker Children's Center, the Boston Foundation, the Echo and Green Foundation, and the list really just goes on and on for those providing financial support, manpower, and programmatic ideas. And that even extends to the Kennedy School, where a lot of this was really fleshed out and really helped the program evolve. In the year or so, year and a half that I've been working hard on this program, I found that collaboration is terribly difficult, terribly messy, but it's just so very necessary. Perhaps with the incoming administration, children will become a priority again. I certainly hope so. But I think that for those of us who work, as they say, on the front lines, for those of us working in communities, we don't have the time. We just cannot wait for others to act. We must and can share wisdom and resources to make a difference in children's lives. Thank you.
We have just a few minutes for questions, so if people would like to ask a question, if you could get to one of the microphones here. I don't think we have any upstairs tonight, do we? No, I don't believe so. So if you have a question, and so on. Yes.
I have a question for all three. One thing that I noticed was missing of direct mention in any of your talks was the issue of child abuse, physical abuse or sexual abuse. And it just seems things that I've read in the papers and such really point to that as a very key factor for the health of children, the education of children. My question is, does your talk tonight that didn't directly mention that, is that a signal that you think that sexual abuse or physical abuse is really symptomatic and is not the best source or best place of intervention for any programs?
I would like to address that. Avanza was one of 9 national primary prevention programs in the area of child abuse and neglect, doing the same strategies that we were doing to prevent education problems. We also see the mental health work. So they're all interrelated. What we found with our parents is that most of them were victims of abuse and neglect, including sexual. Towards the end of the 9-month program, we have one session called Going to Your Past. And now that you know what children need and develop, let's analyze your past and see what happened in your own life. Did your family provide this, or what happened? What we have gathered every single year, no matter which program it is, that all the parents cry because we open up really severe wounds. And that is when we immediately try to plug them into the mental health services. And we need to be better at doing that. But what it has told us is that somehow they never really addressed that issue and tried to put it behind, and it finally surfaced. So yes, those are one of the demographic conditions. In fact, another one that we found out from our Carnegie study is that over 50% of the families had experienced some kind of adverse condition in their situation in their life, including child abuse and neglect. And family violence, the father beating up on the mother, or the children winding up in the hospital because of abuse.
I'm listening.
I'm sorry, we also had another program from the Protective Services for child abuse and neglect. And we treated that program a little different from this one, where we started with a home-based program and then brought them into the center-based program, because this was their last hope of losing their children. And we found out that we needed to start on a one-to-one first and then put them in a group setting.
And I would actually add that child abuse, sexual abuse are very integral components of what we're trying to do. When you think in our mission statement, the people we're trying to reach are the hardest to reach, and often the victims as well as the perpetrators of abuse are these types of people. And I think our first step in handling this issue is creating an environment where people who have been marginalized who for whatever reason feel threatened to go to the traditional centers will start with a place like the Family Van where they can begin to discuss these issues and be guided towards more appropriate and comprehensive services for those issues. So I think that's definitely a population that we welcome to the van.
And listening to the presentations, first of all, let me say that I am very impressed by the dedication and creativity of both Dr. Rodriguez and Dr. Dorsey and what they're doing. And I'm also, though, a bit concerned that these are still small efforts compared to the very large problem there is out there. And I got the feeling from listening to all of the speakers that in a sense, people have had to detach from the existing agencies and public schools in order to do what had to be done. I have a concern about that because I'm a potential urban superintendent. That's what I'm trained to become. And I'm very concerned that we begin to look at this in a more holistic way and try to find ways to, again, link with those schools. And I'm wondering if efforts are, I heard you say that there are clinics in the schools in San Antonio. There are some, and you're also thinking of putting some in other schools. Your program is very new, Dr. Dorsey. Are there any plans to link up in any way with the schools of Boston or to try to involve schools and other agencies, or do you see that as just too much right now?
Well, I can tell you, I think I'm probably going to regret this as soon as I say it, but I'll say it anyway. We have really looked into working with the schools because in a sense you have a captive audience of young people who you can educate and counsel and really offer your services to. But one of the many things that we do, which I neglected to mention, we distribute condoms, lots of condoms, and people have not been necessarily supportive of that notion, but we stand by it. It's integral to our mission and our mandate, and we will not change that. So I think that we're going to have to navigate some pretty touchy political areas, but if the schools want us there, I think we have a lot to offer. But I think that it would require a lot of advanced work because I think school nurses and other clinics are doing a good job, and we don't want to overlap services. We don't want to serve as an adjunct. We want to help where help is needed. So I think that a lot of advanced preparation would be required before we got involved, but it's certainly something that we are very interested in doing at some point down the line.
I think the greatest thing that has ever happened is the Even Start grants that are being distributed throughout the country. Avance is the recipient of an Even Start grant, where we're getting the same model and taking it into the schools. It's called the Avance on Wheels, because there is no space in the schools, so we almost have a similar program in the school system. Whether the schools provide the services or whether they link with an existing organization is the question. To me, I would prefer that they link with an existing nonprofit organization who has been trained to work with the population and who have the skills that can be different from those skills that teachers have been trained to provide in a daily basis. Communities in schools is another example where you bring in the WISE, the health, the parenting, and all other kinds of services in the school, and it can work very, very effectively. But where I think there might be problems is when there's an expectation that the teacher teach and also take care of the social problems. Dr.?
I think there's been a fair amount of teacher bashing and other depreciation of the schools. It's quite unfair. A lot of it is just really cheap shots. It's almost easy to get a laugh by taking a crack at the schools as by taking a crack at the Congress. And our experience has been that there are a lot of terrific people out there who very much want to upgrade the schools. They're working very hard at it and have responded very well as best they can. I mentioned what's happened with the Commerce schools. They're spreading across the country up until very recently with great difficulty. I mean, there was hardly any funding and very little encouragement and so on. I mentioned the Slaven schools at the elementary level. We had a meeting in San Diego 2 weeks ago on the turning points of middle grade school reform. 3.5 years later, what had happened? We've supported state efforts. There were people from 17 states there, and I want to tell you, it was authentic inspiration for me what these people were doing, basically on a shoestring. But fundamentally, there's a movement now, a middle grade school reform movement based in part on turning points. And I think that the notion of working with the existing schools to strengthen them is a realistic proposition. And to talk about essentially one way or another doing away with public schools and starting all over again is at best naive, at worst some kind of revenge motive, which doesn't make any sense to me at all.
Hi. All of you have mentioned in one way or another the need to integrate various aspects of social policy on a community level. And I'm questioning what can be done on the state or federal level to support that kind of intervention and integration of services, since the way the bureaucracies are set up right now and the ways policies are implemented don't generally support that. Second part of that question, obviously, is there have been a few oblique references to the Clinton administration and what in particular might be one or two of the most critical things that could happen on the federal level at this point.
Well, I think there needs to be a bottoms-up approach, and that's what Avance is all about, and a top-to-bottom approach, you know, where people in the state level or at the national level really need to integrate the different disciplines, like health needs to talk to education, to labor, to mental health, to delinquency funds, and so on. All these disciplines need to come together at the top and at the bottom to where people then can provide the services also at the bottom.
Well, I touched briefly on a couple of things that I'd like to see happen at the federal level, which would not be exclusively federal, but federal leadership and what would be some kind of federal, state, local, private undertaking. One is an adolescent development initiative that would link education and health along the lines of what I very briefly sketched and what is spelled out more in turning points, and then the 0 to 4 initiative, the kind of modernized 21st century Head Start that Lee Shore and Julie Richmond have been advocating. Those are two modules. In my view, they might be down payments on President-elect Clinton's very ambitious health care reform. He has staked himself out profoundly on health care reform, and as Joe Newhouse outlined for our group this morning, it's an extremely complex and ambitious undertaking. And while that's being worked out, and there's great technical and political difficulties to work that out, it seems to me to be useful to have a couple of modules that are in effect doable down payments, much less expensive than the ultimate enterprise will be. And so those are my two favorites. Head Start of the 21st century, will that do, Lee, or prefer some other term? And an adolescent development
You call it Head Start of the 21st century.
Well, I think it all has to be. It has to be in some way. It has to have face validity for the American public about how you support these things, and I believe in some way it has to be federal, state, and private in a cooperative mode.
There has to be different partnerships working together, not only talking but pooling the resources. Another initiative that is going on at the federal level that might be able to create what Dr. Hamburg is saying is the CCDP programs, the Comprehensive Child Development Programs. Avance also is a recipient of that $5 million grant that followed 120 families for 5 years. That's right in the middle of following 120 families for 5 years. And these are programs that work with children from 0 to 3 and their families in a very comprehensive way. At the end of the 5 years, there's going to be an analysis to see, you know, does this program make a difference? And can that be the evidence that we need to have to prove that Head Start needs to go down? It is funded out of Head Start, and Apton Associates is conducting the research.
Forgive me if this question is perhaps a little unclear, but I wonder if the relevance of a national database of children and more specifically those that do and do not have library cards, those that in terms of from birth actually, wouldn't this be something that would be possible with the technology that we have? And why aren't libraries specifically doing more to promote their services? Why aren't there more, shall we say, on children's television? Why aren't there more efforts to analyze library adequacy? I was very fortunate in coming from an area where the library was open on Saturdays, and it seemed like a good number of the children did attend. I would imagine that experience in and of itself, I mean, if we had some sort of comprehensive, attractive library service available to particularly areas which haven't had them, that this could be really meaningful. I was successful in securing the sponsorship of a National Library Card Month when the Freshman Congress was here a few years ago. But it didn't seem that the program was very well promoted. It was, and forgive me, Dr. Hamburg, if I say, it was characteristic of the Congress in some sense, in that there was a bill that was passed, and yet we never know what percentage of the children of ages 7 to 11 had library cards or got new library cards because of this program. What I'm asking, I guess, is to what extent, and I know that you're very sensitive about people being afraid to give information, which of course in our day we were never afraid of that, but I mean, if you're not doing any wrong. My question is, to what extent has technology, comprehensive databases, appropriate sorts of, shall we say, promotion? I mean, if you go to the projects, all you see is ads for beer, for alcohol. You never see an ad for a library. You never see an ad for, you know, a park district, or, I mean, what essentially happens is these services, if they are available, aren't, well, I'm asking Cheryl, I think, because I think you're probably the person that would, you talked about, you know, relating to resources that already exist but don't exist.
Right. Unfortunately, the library issue has not come up in our work. But I think I'll actually move tangentially to talk about maybe the role of technology in some of these efforts. I think they're important, number one, when you talk about databases. I mean, I spent a lot of time talking about sort of the human success stories, but in fact, for evaluation and replication and longevity, numbers, data are really needed. So sort of developing the appropriate technology to track successes, to track failures are really critical in programs, even as small as mine. I would also add that technology may have a role fundamentally in helping with some of this coordination and collaboration. I mean, just the wealth of programs existed even here in Boston are just mind-boggling. And for someone with a number of degrees, I still even get overwhelmed with it all. And I can just imagine how some of our clients feel with that. And perhaps down the line, sort of utilizing some of the fast, good technology, maybe sort of have a ready, accessible database to punch in a few numbers, a code word, a lead word, to really direct people to the most appropriate services. That may make our job easier one day on the van. And perhaps, I mean, I think our mission, although we're sort of dealing with prenatal care, reproductive health, our mandate is even broader than that. And I think sort of literacy, libraries, encouraging children about the importance of education, that's just as important to what we do as referring people to medical services.
At Avanza, we make every mother get a library card for their children, and we take them to the library on a monthly basis.
All right, well, listen, we talk about these problems. It's easy to get discouraged, but it's also easy to get inspired, and I hope that the ratio of inspiration to discouragement here was very high. I want to thank Dr. Hamburg, Dr. Rodriguez, Dr. Dorsey for giving us their time and for their inspiration for the future. Thank you very much.